So now we're moving to Amsterdam. Professor Annema Jauke, great pleasure to have you on board. How's things going in Amsterdam?
Good morning, Felix. Dear colleagues, it's a real pleasure to join this event from Amsterdam. And this morning we will show you a combined EBUS and EUS-B procedure. But first, let me discuss the room setup. The patient is lying on his back, and I'll talk you through the room. To my right is Wendy. She's a sedation specialist, and she makes sure that the patient gets deep sedation using propofol, spontaneous breathing, propofol sedation. To my left is Annette. She will help with the equipment. And then we have Yvonne and Marielle, endoscopy nurses, who will help me with the procedure. First, I would like to show the slides of the case. And the case of this morning will be a 49-year-old man who had continuous cough. He was diagnosed by his primary physician with COPD Gold 1 and had been a smoker for many, many years. And due to his persistent cough, the primary care physician made an X-ray, and there was a small abnormality to be seen. And then it was decided to make an integrated PET-CT scan showing abnormalities in the right upper lobe and also some mediastinal abnormalities. And on the next slide, we'll see the imaging. And first on the pulmonary window, you might appreciate the tumor, the mass in the right upper lobe. It's a little bit irregular shaped, close to the thoracic wall. There is no pain if you ask the patients. This could be compatible with a clinical T1 tumor. And on the FDG PET uptake, you can see quite vividly that there is FDG uptake in the lesion itself. On the next slide, we'll see the mediastinal setting. And the nodes in the mediastinum are normal, short axis maximum 10 millimeters. Only there is one region where the nodes are slightly enlarged, and this is in the region 4R, paratracheal to the right. The short axis is around 12 millimeters on the CT scan, and you might appreciate that there is FDG uptake in the node. And on the other image, you see some slight uptake in the hilar as well. Next slide. So based on radiology and the clinical characteristics, it's a case of suspected lung cancer in the right upper lobe with possible N2 involvement, which would qualify for a stage 3A non-small cell lung cancer. And the goal of this procedure is to perform an EBUS and an EUS-B, do a systematic evaluation of the mediastinum, and specifically have a focus on the region paratracheal to the right, 4R, 10R, 11R, get tissue out of it, and find out if we can do diagnosis and staging of lung cancer just using the EBUS scope. We'll show you the anatomy and the sampling. And for this case, we use the Fuji EBUS scope. And one of the nice things of this Fuji scope is the angulation of the optics. This is only 10 degrees, giving you a very good endobronchial view. And you can very specifically see how you position the needle into the endoscope. Now, trick one, when you introduce the EBUS scope, is to ask for a chin lift. And then I'll introduce the scope through the mouth and look for the vocal cords. We can see the vocal cords and just introduce the endoscope into the airways. So now you see the Fuji EBUS scope into the trachea, and the white line represents the ultrasound head. And below you can see the tray where the sheet comes out. When we do a diagnosis and staging of lung cancer, it's important to do the systematics. And I will show you now. I'll turn my endoscope to the left have my thumb pressed downwards, and you might appreciate that the ultrasound transducer goes to the wall. I lose the overview, but I see something else. I see something black. And I asked for the Doppler, and here we can see the aorta, very nicely depicted. And when I just slide the endoscope down, we can see a very tiny lymph node, paratracheal to the left, under the aorta, short axis estimated to be 3 to 5 millimeters, vague borders, maybe some fatty sign in it. This is station 4L, contralateral, and it seems normal to me, not enlarged. Ultrasound characteristics compatible with a benign lymph node. Then I bring the scope back to the trachea and I enter the left main bronchus and I press the ultrasound transducer to the subcarinal area. I suck away some mucus and I try to visualize station 7. And we can see the lymph nodes. There is this fatty sign, and this is a sign of malignancy. Then I bring the scope into the left main and bring it to the carina to the left and check for station 11. And there's just a flat lymph node, short axis 4 millimeter, completely normal. And now we move to the area of interest, and that's paratracheal to the right. Again, I turn my wrist, press the ultrasound transducer down, and I look for the azygos vein. Oh, look at this. You can even see the valves in the azygos vein. Beautiful imaging. And Annette is giving you a Doppler as well, showing that this is the vessel, the flow in the azygos vein. And now the Doppler goes off, and then we slowly go upwards. And here we see a lymph node. You can also see the azygos vein draining into the superior vena cava. It's very beautiful imaging. And on top, there is a lymph node. It's enlarged up to 15 millimeters. And you can see sharp borders, a hypoegoic texture. And this is station 4R. And to me, this is suspicious. If I then slide down under the area, then there is the region 10. Patient starts to cough a little bit. I give a little bit of lidocaine. And what I then can do is go to the area of 11 in the hilum. And here we can see in the carina, there is station 11, and this is also slightly enlarged. So we've done a complete inspection and we will sample lymph node station 4R. And now I'll get the needle and we'll use the Mediglobe Proflex needle, 22 gauge. And we try to sample the lymph node. So Felix, what do you think of the ultrasound characteristics of this lymph node?
Yeah, Joke, you already mentioned that lymph node position 7 with that fatty lesion in between looks more benign, but 4R I would really stage also. I think that is might be a malignant lymph node. Joke, just a question back. You used the 22 gauge needle. Do you have seen any difference regarding the needle size?
Yeah, that's the whole discussion. The needle size. The standard is the 22 gauge, but there are also smaller needles, 25 gauge, or thicker needles, 19 gauge, and also needles with different tips, like the crown tip, which we'll see in a minute. I'm now in the trachea, and I'll show you puncture technique. Here you can see the sheet coming out. It's blue, so it's very visible. And with the twist lock, I lock it. Then I bring the ultrasound transducer up and we zoom even a little bit in. We fix the endoscope near the mouth. And then the needle goes out. I make it sharp. And we go into the lymph node. We can zoom the ultrasound transducer a little bit more in on the lymph nodes. And here we see the needle. And can we zoom in a little bit more on the lymph nodes? We can see the 22 gauge needle into this lymph node. I go up and down, and we'll use for the first needle pass, we use the slow pull technique to get some tissue out.
Yeah, Jouke, the audience is observing you carefully. The big question came directly, why you don't suck on the needle?
Okay, this is a continuous discussion, suction versus no suction. Sometimes without suction, you get already adequate material, and with suction, you can sometimes get a lot of blood. There has been very randomized trials, not clearly indicating a preference for suction versus non-suction. If I get little material, I'll definitely use the suction.
Yeah, I think this is what most of us doing the first attempt without suction, and when it's not enough material, then just add suction. Yeah.
Now you can see how we work with the material. You can see the blue sheet, you can see the needle, and we put some material on the glass, and we'll make a smear for on-site cytology. And we also put material introduced for a cell block. And then we can already do some on-site evaluation. And can I now get the crown tip needle? So if we talk about needles, and it will be one of the topics of today, we have sizes, 22 gauge versus 19 and 25. We have the mediastinal cryobiopsy, which you will see later, and you have different tips on the needle, the Procore, the Acquire, and the crown tip. And we'll use now Mediglobe, a 22 gauge with the crown tip. And this tip is specially designed to get optimal material, and studies are pending to show its possible benefit over needles with a normal bevel chip tip. Now, again, I'm in the trachea. You can see the sheet. I have a protected working channel. Then we move again to the target lesion. We'll fix the endoscope. And now we go into the lesion. And maybe now we have the stylet completely out, and we put suction on it. So you can see the tip, the crown tip on the lymph nodes 4R. And you might appreciate the tip of this needle. It's quite good visible on the ultrasound screen. And I just move up and down, and I can target exactly where I want the tip of the needle to be. It's close to the vena cava, and I go up and down, and we now stop the suction. I remove the needle again. While the material will be processed, I can again show you briefly the systematic EBUS. So in the trachea, go to the left, aorta, station 4L.